Hey guys, and welcome to Master Your Medics. Now, a couple of weeks ago, we saw a case of an inferior STEMI with associated RV infarction. This week, we're also going to see a case of an inferior STEMI, but see if you can tell what other portion of the heart is affected. Let's go ahead and take a look at the case. So this was a 67-year-old male with intractable nausea and vomiting and abdominal pain. Now, his pain was epigastric in location, non-radiating, constant, dull, and occurred after eating a meal. He took Tums without any relief, and the pain, he said, was gradual in onset over minutes, and when paramedics got there, he appeared to be in severe distress and was vomiting. Now, his first blood pressure was low. It was 88 systolic, and they initiated treatment immediately with IV O2 monitor. Saline was running wide open, and they obtained this ECG. Now, go ahead, pause the slideshow here and see if you can tell what's going on in this ECG. Now, at first glance, there are abnormalities, but before we actually call it a STEMI, just go back and take a look at it in a very systematic way, like you always do, with rate, rhythm, and look for the abnormalities after that. And this really is, a normal sinus rhythm with P waves followed by QRS, not T waves, but there are also some ST elevations. So pay attention to that. And especially in the inferior leads, one sees elevations of both in limb leads 2 and 3, with ST elevations in lead 2 being significantly greater than lead 3. Remember, in this case, lead 2 has a more direct view of the inferolateral aspect of the heart. So it kind of gives us a clue about what's going on here, right? In addition, limb lead 1 has some elevations, isoelectric, but maybe some straightening or elevations. I can see that there. And then the lateral leads V5 and V6, there are ST elevations that are pretty significant. And then the anterior precordial leads V2 and V3 have depressions. So this, in fact, was what was thought to be an inferior STEMI with likely a left circumflex occlusion. So the patient was pretty sick, went to the cath lab and in fact had a left circ occlusion, 100% occlusion, got stented and did pretty well. The important thing here is to understand that lead 2 looks directly at the inferolateral aspect of the heart, whereas lead 3 looks more at the inferior aspect and the RV. So when lead 2 is greater than lead 3, it gives you a huge clue as to this being an inferolateral STEMI versus an inferior MI with RV involvement. So to summarize, inferior MI with lateral wall ischemia or MI is going to be, probably highly suspected in patients when you have ST elevations in lead 2 equal or greater than in lead 3. And ST elevations in limb lead 1 would be elevated, maybe AVL sometimes, along with ST elevations in precordial leads V5 and V6. Now, typically, you're going to see ST depressions in the anterior precordial leads V1 through V3. So be aware of that. And don't miss a posterior wall extension because that typically the PDA is derived from the RCA in about 85% of patients, but in about 15% of patients, the PDA comes off the left circ. So in a patient who's left-sided dominant, which means that the PDA comes off the left circ, they very easily could have a posterior wall MI also. This patient was sort of on the cusp of having that. So there's the morphology of your typical posterior wall MI. Remember, you're going to have tall, broad R waves, right, with a dominant R wave that is greater than the S wave. So the RS ratio should be greater than 1. And this case was not quite like that. You're going to have a horizontal ST depression and an upright T wave. So kind of on the border of this being a posterior wall MI also. All right, so there's lead V2, and you can see that, you have a slight R wave there, but the RS ratio is not positive. You have some ST depressions and a positive T wave, right? So that's it for this week. This is a case that illustrates the importance in understanding the difference between an inferior STEMI with RV infarction versus an inferior STEMI with a lateral wall infarction. Okay, see you next time. So long for now. Please leave your comments and questions below. Have a nice week.